The ACA, 5 years in. A couple years ago, I mean, the big image was the train wreck, the fiasco when healthcare.gov didn't work very well. Toward the end of 2013, it looked perhaps as if more people were going to get their insurance canceled than were actually going to be newly covered. There were a lot of fears about how things were going to go. And things have gone more smoothly since then. So what can we say about this point in time? Let's start by a slightly different version of a question that Dr. Curry asked you. Okay, interesting. So some of the no opinion, mixed opinion that Dr. Curry got may be revealed in choice number 3. Certainly, as he pointed out, you guys are probably a little bit different from medical students nationally, but that's interesting. So we've done a bad job if at this point the problems that the ACA was intended to address are not somewhat clear to you. And they fall under 2 headings, the cost problem and the coverage problem. How, at this point, should we assess the ACA? I mean, how should we assess any huge and complex public policy which is put into place? I'm proposing here what seems to me a fairly low bar for anything as ambitious as the ACA that it should achieve. I mean, it should address the problems, and it shouldn't do a whole lot of major harm elsewhere. So let's see how the ACA measures up, if that's the kind of yardstick that we might put into place. Now, how did the ACA go about addressing the problems? I mean, this is basically what it did. Make some changes in the small group and individual market, expand Medicaid, both those things to address the coverage problem. Mandate participation, that's important for the individual market to be viable. And that, per the CBO in 2010, as Dr. Curry explained to you, the projection was that the fees from those who are going to, or the participation of those now uninsured who are going to buy insurance, combined with the taxes that the ACA has, is going to be sufficient to pay for the costs of the entire law, including all the subsidies. So in 2010, what was the projection for what the CBO, or for what the law was going to do in regard to the uninsured? Basically, by 2018, we were going to go from 50 some odd million down to 31 million. And by 2015, 25 million. We'd be most of the way there. We'd be 2/3 of the way there in terms of how many newly insured people there would be. So what actually happened? Well, in 2013, we had a bit of a fiasco, but 2014 and 15 were a little bit better. Now, just in terms of the exchange, there were probably several million newly insured people in 2014. In 2015, the numbers are better. How many newly insured? As of that time, perhaps, I'm going to say perhaps 3 million, and Dr. Cortez is going to give you different numbers. Part of the message is that nobody really knows, in part because the administration chose not to collect important information when people sign up for the exchanges, such as, were you uninsured before you bought this insurance? So the estimates are all over the map. My estimates are going to strike him as a little bit on the low side. His strike me as a little bit on the high side. But you can sort of take all that in. Medicaid, if half of the new enrollment as of May was uninsured before taking the new Medicaid and also was newly eligible by way of the expansion, that would mean roughly, I would estimate, 6.5 million people newly insured. So new access to care. I mean, this is sort of my sort of ballpark estimate I was telling Stefan earlier I was in the 10 to 11 million range. The numbers don't look quite as good the more I looked at it. Stefan's going to tell you, I think, 15 to 17 million. You know, we can argue about that. So what was it hoped the ACA would do? What has the ACA done? A little bit of a difference between the two. We're not quite as far along as it was hoped that we would be. Question mark. How much better are we going to get? How will the ACA do in the next several years? There's another side to the fact that lots of people, and it's great, that lots of people who didn't have coverage now have coverage. That's an important thing, and that's a big accomplishment. But part of the other side is, what about those who, for instance, were eligible for the exchanges but didn't buy insurance? What about them? What about those in the individual market who had insurance and got cancellation notices? Cancellations which had not yet happened because they've been delayed, but which cancellations are probably going to affect, when that delay is finally stopped, 80% of the individual market. Probably 15 million people. There's a lot of people in the upper reaches of the 100 to 400% of federal poverty level income who didn't buy insurance and who haven't bought it yet and may not buy it, some of which may have had insurance, which is now subject to cancellation. Hasn't been canceled yet, but it probably will be. So my estimate is that there's maybe 3 times as many people as have been insured that were not insured before who are going to suffer major disruption, or who have suffered major disruption of their insurance options. Another interesting point is that enrollment in the exchanges seems to be topping off. You know, 10 million with a goal of 30 million by 2018, that's not very far along. But it's not clear that we're going to get there. Enrollment seems to be stabilizing at about 40% of those eligible on the exchanges. And if we look at what's happening, who those people are and why they're not buying, I think we begin to see some very interesting information. One bit being that those who are buying are those at the lowest levels of income. Now, that's not surprising. If you are going to get a lot of subsidy to buy a policy which is going to give you a lot of coverage, and it's not going to cost you very much, well, that's a very attractive proposition. The subsidies tail off fairly quickly in the upper reaches of the income range among those eligible for subsidies, and the policies are just not as attractive. They're not as good a deal. The other aspect of this is that those that are buying these policies are the ones who know that they're going to need services. So in terms of why are the people in the upper reaches not buying the policies, I mean, this is just an example. You're a family of 4 making $60K. The premiums actually and co-pays actually amount to quite a bit. If you buy, you're paying almost 10% of your income for a policy which, if you're healthy, may pay you nothing. It doesn't seem unexpected that a lot of people would say no to that. You know, even in spite of the penalties, even in spite of the mandate, which at this point is not being enforced. Now, for the exchange market to work, the demographics of the individual market have to resemble the demographics of that population that's eligible, including 40% of people buying insurance need to be young and healthy. Is that happening? No, it isn't. Far fewer young and healthy people are buying than need to buy for this to work. Those who are buying, naturally, are sicker. Now, think back to the first lecture we did on Insurance 101, you can infer what the consequences of this are going to be. I mean, what does a risk pool that has more sick people in it that is financially sustainable, what do we call that? Adverse selection. So adverse selection is happening as we speak. What is that? What are the financial implications of that for the individual insurance market? I think Jack showed you a little bit of this data, but what we're seeing is that the insurance companies' proposals for premiums for next year compared to last year are very, very different, and in fact, very, very much higher. Now, the optimistic way to look at this, this is the first step. The companies are going to have to negotiate with the state insurance commissioners. This is just sort of a bargaining chip. But what we're seeing is that the largest players in the largest markets are actually making the highest rate proposals. The insurance companies with the most data, the most experience, and the most knowledge of what their experience is likely to be in the future are asking for the highest increases. Blue Cross of Tennessee, good example, almost a 40% increase in its premiums for a 40-year-old smoker in 2016 compared to before. Now, it's interesting, to look closer to home. Look at what Blue Cross of Alabama is doing. If we look at what they proposed, we begin to look at their non-individual policies, and the rate increases look, well, they're a bit high, 11, 12, 13%. I mean, that's a little bit worrying, but not out of the range of where things have been in the recent past. But then look at their policies for the individual market. They were proposing rate increases from the mid-20s up to 70% for 2016. Now, this is all a very natural consequence of the changes that were made in the market. You engineer a situation in which policies are relatively expensive for young and healthy people. They choose not to buy them. The mandate has no teeth, so they don't have to buy them. You end up with a risk pool that is not going to financially work, and the insurance companies are not trying to make it work. They're trying to collect enough money for this to work, which they have to do. Now, of course, the administration, with a logic that, I don't know, it's hard for me to find a word for it, but what have they done? They've made changes in a market, the effects of which were entirely predictable. And when those effects followed, which could have been predicted as night follows day, their response to what is an impending death spiral is to vilify the insurance companies. Get the insurance commissioners in the states to crack down on those villainous insurance companies who are trying to have these heinous increases in rates. Words fail me. So, looking at the individual market in particular, the ACA has given us a good result in terms of a coverage improvement. It threatens disruption to many millions of people beyond those who have been newly insured, and it threatens a death spiral in the insurance market. Not a pretty picture. But unfortunately, it gets worse. If we look at what the ACA pretends for the medical profession and for the healthcare organizations that provide care, what's going to happen? We're already seeing it happen. Insurance companies are consolidating. Healthcare providers are consolidating. But to be fair, that was happening already. Providers have imposed high prices on insurance companies for a long time. Insurance companies needed to fight back. One way to fight back is market power. They've been successfully doing that. So healthcare providers say, well, we have to fight back against the insurance companies, so we're going to get bigger, so we're the only game in town. And that's kind of a vicious cycle. But everything about this is accelerated by the ACA. All of the rules that the insurance companies now have to follow with regard to the character of their policies make competing much more difficult. And for that reason, their market power becomes much more important. So of course, in places where there are multiple insurance companies, they're joining together. And the consequence of that is going to be fewer choices for both individual providers and individual patients. As we all sort of are ants among the behemoth healthcare institutions that we increasingly will have to work for, and the behemoth insurance institutions. So I would regard that as a relatively negative consequence of the ACA. I think another important aspect of this is what about the government's fiscal position? And Dr. Curry showed you a projection from 2010 in which the lines, the deficit line didn't look much different under the ACA. Unfortunately, that projection is probably highly unrealistic. Projections since then have been made on the basis of more realistic assumptions, and the more likely scenarios are that the deficit is going to start to worsen in a major way very quickly, as per the Medicare trustees in 2012. So the slide that Dr. Curry showed you and that I also showed you with the expenditures per GDP and then that black line receipts, that expenditure bar is going to rise, probably fairly precipitously. Now, unfortunately, that's not the end of the bad news part of the story. We also have to consider the effects of the ACA on the rest of the economy. And the ACA has a lot of implicit taxes in it. Now, what are implicit taxes? Implicit taxes is when the government advantages a particular condition or a particular activity and leaves other conditions or activities relatively disadvantaged. That amounts to a tax on those other activities, even though it's not a direct tax. And what the ACA does, it has indirect taxes on income because of the subsidies and because of how Medicaid interfixes with the subsidies. And it has probably even more troubling indirect taxes on employment. And just an example of this, what happens to you if you go from 138% of the FPL to 138% of the FPL plus $1? You're not eligible for Medicaid anymore. From having an out-of-pocket maximum of $800, suddenly you have an out-of-pocket maximum of roughly $3,000. I mean, unless you go fairly far above that threshold, you're worse off. So strong incentive, not to take a job. It's going to pay you a little bit more than a job that would pay you a little bit less and allow you to stay on Medicaid. The picture for full-time versus part-time employment, I think, is even more striking. This is a little bit hard to grasp just in a second, but the basic picture is, consider two positions, one full-time, one part-time. The full-time position costs the employer $56,000. The part-time position costs the employer $42,000. But if you go through the impact of the subsidy for the part-time position and the absence of the subsidy for the full-time position, the value to the employee is actually identical. So, you're a part-time person, 29 hours a week. You're considered going to 40 hours. Why should you do that? The money and the health implications are going to be exactly the same. A strong incentive for part-time work, a strong incentive for employers not to offer full-time work, to offer part-time work instead. Now, the administration, very interestingly, has noted this effect and has pitched it, well, this is a chance for people to chase their dreams, You know, people will be able to retire when they want. They won't have to work, perhaps if they didn't want to work. You know, how great for them. Now, there's a certain logic to that, to saying that. But what about if you're thinking about it from the standpoint of the taxpayers who are actually paying for people not to work, paying a subsidy so that people cannot work and achieve their dreams? Doesn't seem very fair. But the other problem, aside from the fairness, is what it's going to do to our productivity, what it's going to do to the size of our economy, what it's going to do to our GDP when the employment and labor that would have happened without the ACA doesn't happen. Remember our fiscal position. It's not just how much we spend, it's also how much there are in tax receipts. And how much there are in tax receipts is directly correlated to GDP. The ACA is going to directly diminish the federal government's solvency, not merely by increasing healthcare expenditures, but by diminishing what the government takes in. So that trajectory toward fiscal disaster, we've just sort of put our foot on the gas. So the ACA, I mean, my argument would be it's not affordable. It's not healthcare reform. It is coverage improvement, and I don't want to minimize that. I think that's a wonderful thing that the ACA has achieved. But I would argue that that could have been achieved. We didn't have to do the destruction and damage that the ACA is doing elsewhere to achieve the coverage improvement that we have. Yes, for those people, it's a light at the end of the tunnel. Not so clear that it's a light at the end of the tunnel from the standpoint of society, from the standpoint of those who have fewer insurance options, and certainly from the standpoint of the private insurance market. Now, it could have been done differently. We could have had some of the useful aspects of the ACA without some of the damaging aspects. I think it's worth pointing out that the ACA was promoted, you know, not in terms of pardonable exaggeration, in terms of how it would affect people that were not uninsured, not in terms of political hyperbole, acceptable political hyperbole or political spin. It was promoted with outright assertions that were flatly false and known to be false by those who were asserting them. And the ACA was passed because of, in Jonathan Gruber's memorable phrase, the stupidity of the American voter. That's unfortunate, I would argue. Now, having achieved some clarity, I think, about the ACA, I'm going to turn the mic over to Dr. Cortez, who will plunge you back into the fog of confusion and bewilderment, which is his role here. I want you to listen carefully, of course, to what Dr. Cortez has to say. But I think it's also important, you know, not only, I think it's helpful when someone's making a case to not only hear what they say, but to know where they're coming from. My slides are not done. So, as you listen to Dr. Cortez, there's a question I want you to ask yourself, and it's not exactly the question, do I feel lucky? Well, do you, punk? But it's related to that question. And the question is, given the intellectual affinities that clearly indicated by this picture, can you trust Dr. Cortez? Here you go.
Is this what you're advancing with? Good. Okay.